Hello, and welcome to our review of the lupus literature. We record these podcasts for you every month, so you'll always be able to keep up to date with the latest literature and expert opinions. My name's Ed Vital. I work at the University of Leeds, and today I'm joined by Richard Furie, who's Chief of the Division of Rheumatology at the Department of Medicine, Northwell Health, New York, and Professor of Medicine at the Zucker School of Medicine at Hofstra or Northwell, and Liz Lightstone, who's from Imperial College Healthcare NHS Trust Renal and Transplant Centre in Hammersmith in London. Welcome, Richard and Liz.
Thank you.
So we've chosen two papers here to look through. One about arthritis in ANA positive people and one about lupus nephritis. So the first one of those is one that's actually from my group. So what did you think about it, Rich?
Well, let me just first give the title, and it's ANA-associated arthritis, clinical and biomarker characterization of a population for basket trials. So as you said, it was authored, first author was Jack Arnold, and you were the senior author. So I'm going to ask you a bunch of questions, but let me just try to give a little background. There's little question that many of our ANA positive rheumatic diseases have overlapping clinical and immunologic features. And these include lupus, Sjogren's syndrome, scleroderma, myositis, mixed connective tissue disease, undifferentiated connective tissue disease. I suppose we could even throw early RA into the mix. Yet the treatments might vary according to the label that we bestow upon them. And it seemed like the objectives of this study were to evaluate and characterize arthritis in ANA-associated rheumatic and musculoskeletal disease patients. So my first question, I condensed, and I'm sure I oversimplified the objectives, but perhaps you can elaborate on the impetus to do this study, Ed.
Yeah, you got it exactly right. The starting point was that we had this idea years ago that we said, well, we were thinking then that we were thinking about interferon signature. You've got a high and low population within lupus, and we think the highs are the ones to treat with interferon blocking therapy. And then we were like, well, there's also a high and low within Sjogren's and a high and low within mixed connective tissue, et cetera, et cetera. And so maybe this is a real basket trial situation where you should group people by the biomarker and forget about the clinical features. That's how we started, and we started recruiting this cohort. And then I guess over time, with the interest in prescribing drugs by interferon signature, I think the reality of that's a little bit more complex than we first thought. But on the other hand, we started thinking about exactly what you said, that there's a whole load of other ways that you might group people for better clinical effect. So if I see in clinic tomorrow a patient with lupus who has arthritis, I could say, okay, belimumab, there for you, licensed therapy, there you go. But if I see a patient who's got Sjogren's or undifferentiated, who has exactly the same clinical problem and probably pretty much the same immunology underlying it, they technically don't qualify for that same drug. So this is part of Jack's PhD, where he's doing a very generalized sort of trying to reclassify everything about the ANA spectrum of diseases. But this is just one chunk of it that stood out to us as like, maybe that's the easiest one to put into action, because you don't need to test any biomarkers. Everyone knows arthritis when we see it, and we recognize that it's prevalent across all these diseases. So maybe that's a really obvious basket population.
Yeah, so when I first started reading this article, it seemed very straightforward to me. But as I got into it, it just seemed far more complex than I originally thought, because there was a lot of integration of clinical material and biomarker data. So maybe you can just review the methodology and then go into the results.
Yeah, so exactly. So as you say, we started with this cohort called Definition, which was it was originally designed a bit like there's a similar cohort, a European one called Precise SADS, that the idea was we were going to recruit these people with all these different diseases, and we would reclassify them by biomarkers rather than by their diagnosis. And then we as we decided while we were recruiting it to recruit a lot, to collect a lot of detailed clinical data as well, because we thought, well, molecular classifications don't mean much if you don't know things like what were the clinical features, how active was it, what therapy were on, patient impact. So this cohort definition was 300 patients. They could have any ANA associated disease, and they got so there was a lot of SLE, a lot of undifferentiated CTD, and then smaller amounts of the other diseases. And then we collected the demographics, clinical features with things like indices like SLEDAI, etc., SDI for Sjögren's and so on. The comorbidities they had, the therapies, patient-reported outcomes. And then we did two types of biomarkers. One was gene expression with some gene expression scores we interfere on, but also for other things, and then for flow cytometry. So we collected all that stuff, and then we took kind of two approaches to it. So the first one was actually really simple. Like you say, we started off really simple. It was just descriptive. We just said, out of those people, how many of them have some evidence of there being arthritis? And like it could be a score on a bilager and SLEDAI, or it could be that people had just noted it as one of their problems. We took a broad approach, and that was 215 of the 300 who had some kind of evidence of arthritis. It varied a bit across the disease, 87% for lupus, lower for myositis and scleroderma. And then we just described them, those people who had arthritis across, or MSK inflammation, for all those different features, the demographics, the clinical, the biomarkers, the PROs, and just to see, is this a consistent thing? Is a Sjögren's patient who's got arthritis similar enough to a lupus patient with arthritis, for example? And the general message was, yeah, it was. For most things, they were quite consistent across the different originated diseases. It got a little bit more complicated with the machine learning part, but essentially what we tried to do was then say, is that if we just take those people who've got MSK inflammation, would a machine learning algorithm keep them all in one group? Or would it separate them out into subsets? And if it did separate them into subsets, are those subsets like the old diagnoses, or is it some new way of dividing them? That was essentially what we did. So we put our data into different machine learning model algorithms. We tried a few different ones, and the one that worked for us was Gaussian mixture modeling, which essentially the advantage is it's not quite as hard on classifying people. It's a bit more probabilistic. So like the boundaries can be slightly softer of these groups. And we essentially said, if you've got the ANA arthritis group, which means MSK inflammation group, then we had two subsets, a higher disease activity and a lower. The higher one was 89 of the patients, the lower one was 124. And the high disease activity group that we think might be that's your basket problem population for trials, it was a mixture of different diseases. So we're not splitting back into the old diseases. This is a new group. It had everybody who had swollen joints, but it had a bunch of other people who didn't actually have swollen joints, but all their other characteristics were quite similar. So we speculate that those other people, maybe they didn't have inflammation on the day of the study, but they do at other times, or they're on better therapy, or something like that. So that group of people had lower comorbidities, less osteoarthritis, less fibromyalgia, more RMP and Smith antibodies. All the mixed connective tissue disease patients are in there. Higher bilateral SLEDAI scores, a bit more prednisolone use. So they do seem a more impacted and more inflammatory group overall. So that's, yeah, we think that group might be appropriate for a basket trial.
Okay, so if we distill down what you just mentioned,
yeah,
in a sentence each, one message for clinicians and a second message for clinical trialists, maybe doing early proof of concept studies.
Yeah, good idea. Okay, so The idea for the clinician is that, as far as we can see, if you have a patient who's ANA positive and has MSK inflammation, then in terms of how it impacts the person and immunologically, they seem the same as lupus patients. So it seems logical to treat them the same as lupus, just even though they've got different diagnosis, that doesn't matter. It seems like the immunology is the same, the clinical impact's the same. Then for the clinical trialist, what I would suggest is that in the lupus trials, one of the problems is they're very heterogeneous population, different organs affected, and that makes the outcome measures more complicated and the standard of care more complicated, etc. And maybe those are some of the reasons why the effect size is sometimes small and the trials are difficult. If we did a trial on this basket population, everyone's got the same problem. You could design an outcome measure that's better. I'm sorry, I know you asked me for one sentence. and a more consistent standard of care. And the result of the trial would be beneficial to more people because more of the patients in our clinics would be represented by the evidence in that trial.
Okay, very good. Thanks for explaining that study. And we'll hear about that, you said, at ACR.
The ACR is a more generalized reclassification of all disease, not just arthritis. Yeah.
All right, great. Thank you.
Okay, but I've talked too much. Let's go on to the next one and let someone else talk. So, Liz, you had a look at this one, didn't you? That's about meeting targets of therapy in nephritis.
Yes, so this is a study from several sites in Greece, led by the first author is Papa, M. Papa et al. And it's attainment of EULAR, ERA, EDTA targets of therapy with current immunosuppressive regimens and adjustments in treatment. And it's a real life observational study. And they did something quite interesting because they divided their cohorts. They did a retrospective element and a prospective element from 2022 looking backwards and from 2022 looking forwards to 2025. So a sort of modern era look at outcomes, and they define their responses. So EULAR, ERA, I'll just call them the EULAR guidelines for short for brevity, but they talk about achieving a 25% reduction in proteinuria at 3 months, a 50% reduction in proteinuria at 6 months, and a complete response of less than 0.5 grams at a year. And then there's also, for the patients longer out, there's the definitions from the Bliss-LN trial of a complete response, which is whatever, it's a PERR response. It's proteinuria of less than 0.7 grams and a GFR of greater than 60 mils or within a percentage of baseline, which I have to say is a very soft GFR requirement. And what they show that I think is interesting on at surface level is really quite high rates of response. So by 12 weeks, they've got 72.6% achieving the 25%. That's the panel in the results on the left. And then it goes up and they get really very high numbers achieving complete responses at 1 year. And then if you look further out also, and much higher responses than you see in clinical trials and indeed in American cohort studies. So I'd be interested to see what you would like me to discuss from this. But I think the results are surprising, but perhaps unsurprising when you go into a bit more depth in the paper.
What did you think about this one, Rich?
Yeah, I was kind of shocked by the 70% complete response rate.
Yeah, well, so was I until I saw.
How did that happen?
Yeah.
So exactly. So I go around when I'm talking about lupus nephritis trials and things, I always tell people if you look at the Aurora trial, then the placebo arm there represents a mycophenolate plus steroids, sort of what we used to call standard treatment, didn't we? And the number of people in that who met all these targets was 27%. So I always say it's not good enough. We need to improve it. We need combination therapies. That's so far away from this. Why is that?
Oh, well, I think that's answerable. Firstly, this is an entirely Greek population, an entirely white population. And we know that European white patients are more likely to respond. That's a sort of given. But they also, if you dig down into how they treated these patients, a majority of them had high dose NIH cyclophosphamide. They weren't even having Lupus cyclophosphamide. They were having high-dose cyclophosphamide, some of whom went on to have that for 24 months. And they got lots of steroids, and a large proportion of them needed to swap their treatment. So 20% of patients had to have an adjustment to their treatment in the first year to attain those. So they were looking after them very carefully. They were modifying their treatment according to response or non-response. So that I completely applaud. But mostly what they were doing were increasing their steroids, which I'm not such a fan of. And then they were switching them either from cyclophosphamide to MMF or the other way around. Very few patients had combination therapy. And then they did also look at what predicted a poor outcome, and unsurprisingly, a higher chronicity index on the renal biopsy at baseline predicted a worse outcome. But I think they weren't using combinations, but they were using, dare I say, old-fashioned treatment, really high doses of cyclophosphamide and probably really high doses of steroid. You don't really get much detail, but quite a lot of them were still on 7.5 milligrams or more at 1 year, which I think is far too much. And I've always argued, you give enough cyclophosphamide, you give enough steroids, most people will go into remission, but at what cost?
Yeah.
I used to give in the late 90s, I gave everyone high dose cyclophosphamide. They all went into remission, and all the women became amenorrheic. I induced menopause in every single patient I treated, and that isn't acceptable.
So there's
And nor are
definitely
high-dose
still
steroids.
room for better treatment combinations. I mean, it's sort of, in one sense, it says if we do the right thing, we can get really good outcomes. But what the right thing is may
It
still
doesn't
have
tell you
room.
any further.
May
There's
still have
almost
room.
no patient. I think there's not a single patient on voclosporin, and there's almost no patients who have B-cell depletion or belimumab. So it doesn't add to that conversation. I think it also, there's only one patient, I think, in the whole study who had a repeat biopsy. And the other thing as a nephrologist that I'd like to highlight is they weren't really optimizing the chronic. They do talk about it very nicely in the discussion, but they weren't really optimizing the chronic kidney disease, the CKD aspect of care. So only 50% of patients were on a renin-angiotensin blockade, and almost none. That is an era effect because it's become more popular since, on an
Yeah.
SGLT2 inhibitor.
Yeah, you always have to remember with these studies, if someone's telling you such many long-term outcomes, it means they
Yeah.
started 10 years ago or something. And yeah.
Yeah.
So we still need better ways to achieve these results. Is that kind of the other thing that made me think about was actually a small side project that some of medical students did with me over the summer, which is looking at some of our patients who had got end-stage renal failure from lupus nephritis and going back over sometimes really old records and trying to understand the reasons why. And it's difficult with retrospective data. The picture is complicated and there's lots of different things going on. But one thing that really stood out loud and clear when we did that was it's not necessarily about the medicines we chose, it's about the delivery of care overall. So compliance had been noted at the time in more than a third of them. That was linked to speaking a different language from English, being a different ethnicity, being younger at the time of the onset of the lupus nephritis. It wasn't late diagnoses, as I suspected it was the problem. It was something about the way treatment was being given or being taken. And that may be a factor here, mightn't it, as well?
I think it's a hugely important factor. I recently looked down our list of our patients who reached end stage, and it was exactly the same. It wasn't refractory. And actually, I have a difficulty defining, when you think of CAR T cells coming along and everyone's talking about using them for refractory lupus nephritis. Refractory lupus nephritis to me is the patient we fail to engage with, who just won't engage with long-term treatment. And actually, I think developing strategies that allow patients to be treatment free for years is a fantastic way forward, because that's what they want, and that's actually what they sort of self-declare. But you want them to be safe in that period and actually allow them to have successful pregnancies off treatment. So I think we've got a way to go. I don't think this paper adds to knowing the best combination, but I think it does highlight, if you get treatment in and you get enough treatment in, a lot of patients will do very well. But this is a very select group. They're not a typical group, say, for my practice at all.
harder
So I
to
have a
achieve.
question for you, Liz.
Yeah.
So chronicity again surfaced as a poor prognostic feature. I mean, we've known that for a lot of decades. So, but as I recall in this article, the average chronicity index was 2 or so.
Yeah.
I don't really know what our average chronicity indices are in our clinical trials.
Oh, that's
So
a
is this
great
higher,
question.
lower, the same?
I suspect it's pretty similar. It always increases. So if you ever do a repeat biopsy, it always has gone up because you end up with segmental lesions in everybody, really. There's nobody who gets away with no segmental lesions. I imagine I don't know that it's been reported consistently in trials because it's only relatively recently that everyone's talking about chronicity. So normally they say it's a biopsy showing a class 3 or 4, and they don't even report the chronicity. So it's a great question. And I suspect most of them at baseline will be similar. That's not a very high level of chronicity. But it might be telling you something about why they've got persistent proteinuria, because the proteinuria may be nothing to do with activity, and it's why we need to do repeat biopsies until we have really validated biomarkers, you know, the urinary CD163 or IL-16, if you believe Andrea Fava's work. He presented beautifully at the ASN just now. I think we're getting there, getting towards biomarkers that really do define active disease as opposed to proteinuria, which is a marker of activity and damage.
What I find really interesting at the moment is that if you went back 5 to 10 years, I would say treatment of lupus nephritis seemed to me relatively straightforward. Everyone's getting mycophenolate and steroids induction, mycophenolate maintenance, cycler and Ritux there if you are getting into difficulties. But now it's getting much more complex because you've got a lot of options. There's new options going to be presented at ACR, obinutuzumab, bit of data on DAPI, others just round the corner, different ways to combine them, different things to do if something's going wrong. It's getting more complicated, but in very interesting ways.
It's got much more complicated, but I think the choices highlight what we don't know. And you know, what we currently do, we see a patient with class 4 lupus nephritis, for instance, and we do whatever we normally do. We give MMF and steroids. I do something different. But I don't know which one's going to respond or not, just based on that baseline classification. And we desperately need the application of omics or something to tell us this patient's going to respond to X and Y and this patient's going to respond. Otherwise, we're going to keep doing these sequential changes and you're going to be losing nephrons while you're doing it. Because I really do believe you need to treat correctly the first time. And I don't think we've got any handle on that.
Yeah. So having lots of options is a good problem to have, but it means we have to take quite an active approach to making these decisions. But also, if the decisions are all right and the care delivery is right and the drugs are right, you can get really great outcomes.
I have to say, instinctively, I like the idea of going in hard and pulling back and trying to get control early on rather than going in sequentially and adding in, because I think you set off pathways that you can't undo after a while.
Yeah, me too. Yeah. Okay, fantastic. So I think that's about all we've got time for today. So thanks for joining me, Richard and Liz. It's great to hear your thoughts on all these developments.
Pleasure. It's been fun to look at the paper. Thank you.
And thanks everyone for listening. As always, the slide decks for these papers are at lupus-forum.com. The Lupus Forum is free to access. All the content is free to download. So you can download those PowerPoints and use them for your own journal clubs or your teaching. And if you register for updates on the Lupus Forum, then you'll get emails whenever anything new comes out, or you can follow us at Lupus Forum, or one word, on Twitter or on LinkedIn. Thanks again, and see you next time.